Morning, thanks for the opportunity. So I'll be giving a respiratory update. So I'll introduce a few case studies and using these case studies to discuss respiratory topics and introduce available services at St. George that patients can be linked in with. I'll briefly mention a COVID case since it's topical right now and discuss long COVID. Okay, so case one. So in your clinic, a 64-year-old gentleman presents with exertional dyspnea and non-productive cough. He has no associated chest tightness or pain. This has been progressive over the past year. Previously, his wife reports that he's fairly fit and goes on regular walks. On exam, he's saturating 95% on room air. His rest rate's 20 breaths per minute. He has irregular heart rate at 76 beats per minute. There's no clubbing. Auscultation of the chest reveals inspiratory crackles, no wheeze. His cardiac exam is unremarkable. This is on a background of hypertension, hypercholesterolemia, atrial fibrillation, and he's an ex-smoker, 40-pack year history. He currently works as a taxi driver part-time. Previously worked in a construction with possible asbestos exposure. So he did a bedside spirometry. This shows suggests a restrictive ventilatory defect with reduced FEV1 and FVC, but preserved ratio. An X-ray shows increased interstitial markings. And because of the X-ray findings and his examination, we've gone on and performed the CT. Decided to do HRCT. So what are the benefits or pros of having an HRCT as opposed to a conventional CT chest? So it gives us prone images, which allows better assessment of the subpleural lung in the posterior zones. And that helps differentiate dependent atelectasis or fluid accumulation from actual parenchymal disease. There's also expiratory imaging, which allows detection of airway obstruction in terms of mosaic attenuation. This will help differentiate certain interstitial lung disease from others. So the general radiologist approaches first, is there really an abnormality or there's an issue with penetration or how the scan was performed. So avoiding over-interpretation. And what is the predominant pattern? Is it reticular fibrotic changes or ground glass or nodular changes? And what's the distribution? Is it subpleural? Is it sparing the subpleural region? Is it upper versus lower zones? Is it peripheral versus central? And then any additional findings such as evidence of pleural disease. We mentioned gas trapping or evidence of airways disease. Any lymph node, lymph adenopathy or calcified lymph nodes that might point to a particular cause. So this gentleman has interstitial lung disease, and the general classification sort of those with known cause, so such as autoimmune disease or occupational exposure-related lung diseases that causes hypersensitivity pneumonitis or UIP pattern. Or those with a sort of unknown etiology, of which idiopathic pulmonary fibrosis is the main one. There's other more rare conditions, and then granulomatous interstitial diseases. So there's over 200. Early and accurate diagnosis is often challenging. So often you have to monitor them and do serial imaging. They often go through extensive investigations. And depending on the etiology, they have variable clinical course, and sometimes it's difficult to predict progression at the onset of detection. So go back to this gentleman, you get additional history. So he has no history of connective tissue disease or any examination features of autoimmune conditions. He previously worked in construction, but mostly outdoors with good ventilation. He used some personal protective gear, and there's minimal exposure to concrete work and questionable exposure to asbestos. With regards to his background of atrial fibrillation, he has not had any prior amiodarone exposure. With regards to his home environment, no contact with birds or bird-related antigens, and he has no relevant hobbies in terms of pneumotoxins. So he was discussed, he was referred to Respiratory, who gone through the history again, examined him, done a formal lung function test, and discussed him at a MDT meeting. So the radiologist at the MDT mentioned, look, there's no pleural plaques or rounded atelectasis. It was a typical UIP pattern. So what that meant was there's evidence of honeycombing, traction, bronchiectasis. There was no significant ground glass. The distribution is patchy, posterior, and subpleural based. There were no additional ancillary findings. And the predominant feature is reticular fibrosis. This was compared to old inpatient CT scans from a few years ago when he came in for a CT abdomen, and there was clear progression of disease over a relatively short period of time. His formal lung function showed, again, confirmed a restrictive ventilatory defect with his total lung capacity at 65% or predicted. He had impaired diffusion capacity, that's 45% or predicted. He underwent a 6-minute walk distance test, so he desaturated from 99% to 88% with exertion. And he achieved a distance of 340 meters. His serology was reviewed with a rheumatologist at the MDT, and in essence, it was deemed unremarkable. He had an ANA of 1 to 80 and an equivocal PR7 that was most likely a false positive. So the consensus was he had IPF, idiopathic pulmonary fibrosis. No further investigation is required in terms of bronchoscopy, lavage, or any lung biopsies, and he was commenced on an antifibrotic. So IPF is the most common ILD. It affects older adults, peak age between 50 to 60 years of age. It's a progressive fibrotic disease with poor prognosis, so median survival of 3 to 5 years. Up until last few years or last decade, there hasn't been any treatment that is disease altering, but recently there has been a couple of antifibrotics that alter the course of lung function decline. The radiological features is this UIP pattern. However, UIP pattern can be seen in other lung diseases such as asbestos or rheumatoid arthritis or fibrotic HP. The key features in UIP pattern is there's honeycombing, which is layers of what looks like cysts distributed in the subpleural region, usually in the posterior. It's often accompanied by traction bronchiectasis or bronchiectasis. Reticular opacities or reticular fibrosis is the main feature. Again, subpleural distribution with a basal predominance, and there's no other features to suggest that alternative diagnosis, in particular ground glass changes. So the general ILD management flowchart, they undergo a comprehensive history examination, lung function test, imaging, blood tests to screen for secondary or known causes of ILD. And this information is brought to an MDT. So the benefits of having an MDT is it brings together multiple specialties with different clinical expertise, and they're allowed to come to a diagnostic consensus, if able, discuss the benefits and harm of further investigations, such as bronchoscopies or surgical biopsies, and decision on treatment and monitoring. The MDT is also required to meet PBS requirements for antifibrotic use. So back to case 1, he was commenced on an antifibrotic therapy. The goal was to reduce the decline in lung function. He undergo regular lung function tests, full blood count, and liver functions. He completed his workup, so his transthoracic echocardiogram only showed appropriate mild pulmonary hypertension. He had evidence of gastroesophageal reflux exacerbated by coughing. He was advised lifestyle treatment in addition to antacids as required. He was referred for pulmonary rehabilitation, and you kindly completed his vaccinations. He's linked up with a ILD registry at the hospital, referred to support groups. Most chronic lung conditions are associated with sort of nutritional issues in terms of weight loss, and he was linked up with dietetic services. As the condition progresses, he'll be linked up with palliative care for management of symptoms with advanced care discussion, assuming he is not a transplant candidate. So the key points from our perspective, in terms of triaging the referral, we like to know if it's a newly diagnosed or versus a chronic known interstitial lung disease that you want to be linked up or re-reviewed. And the degree of dyspnea, so how debilitated they are by their lung condition, and whether there's presence of respiratory failure or right heart failure. So in terms of pertinent info, we would like to see on the referral, so the location of where they had this CT scan, best if they can bring the imaging, and again we've discussed why HRCT is preferred. So sometimes the interstitial lung disease is found incidentally. You're welcome to refer them, and we can organise the HRCT at our hospital. So history-wise, often we can obtain a good occupational and environmental history, but sometimes it's difficult to identify what drug exposure there may have been in the past. So any additional information from you would be very helpful, in particular, previous immunosuppressives, previous amiodarone for atrial fibrillation, previous antibiotic use, any chemoradiotherapy in the past. We've discussed the availability of MDTs at most hospital centres to aid in a diagnostic management of ILDs. At our hospital, there's a coordinator and registry that helps with contacting patients, liaising with them regarding drug side effects, script refills, as well as coordinating care with the primary physician, primary GP. And the key thing in terms of early diagnosis is having an index of suspicion. So they present with similar history with a multitude of other respiratory conditions. The X-ray may be unremarkable, so it comes down to clinical exam and undergoing a CT chest. We move on to our second case. This is a 43-year-old female, new onset cough for the past 6 months, which is intermittent. It's mostly dry and associated with occasional breathlessness. It's worse in the morning and with exercise, not triggered by food or posture. It's brought on by cold air and strong perfumes. This is on a background of allergic rhinitis, family history of atopy, no pre-existing heart disease or not on any antihypertensives. She's a non-smoker, drinks socially. She works in an office setting. And examination findings are mostly unremarkable, other than occasional expiratory wheeze. So briefly mention the cough reflex. So it's an important physiological reflex, and it complements the mucociliary clearance. So without the cough reflex, such as people post-stroke, even with an intact mucociliary clearance, they're at risk of aspiration. There's multiple triggers, so it could be pulmonary or extrapulmonary. So not always a lung cause. There's chemical and mechanical receptors. So this is distributed not only in the respiratory tracts, but also in the pericardium, so pericarditis, esophagus, i.e. reflux, diaphragmatic problems, and in the stomach. This is feedback through afferent nerves, through the vagus nerves, and into the medullary control center. This in turn is under degree of control from the cortex. So there is some voluntary control in terms of eliciting and suppressing cough. That comes back later in terms of cough hypersensitivity. The chronic recurrent activation of the reflux arc can lead to hypersensitivity. So there's some plasticity in the neuropathway, and that can promote development of pathological cough. So in terms of classification, so first we divide it into acute, subacute, and chronic. Any acute pathology that becomes prolonged lead on to subacute and chronic. So the most common acute ones are allergy and upper respiratory tract infection. Most subacute ones are due to post-viral, post-infective cough. Some respiratory infections can cause prolonged cough that extends beyond 3 weeks, so such as mycoplasma, adenovirus, and pertussis. In terms of chronic cough, we generally use a time period mark of 8 weeks and beyond. So the 3 most common ones, which you guys know well, are upper airway cough syndrome or postnasal drip, asthma or cough variant asthma, and gastroesophageal reflux disease. However, it's important to exclude the other causes, such as drug, in particular ACE inhibitors, eosinophilic bronchitis. So that's patients with eosinophilic-driven cough that is not asthma without any bronchial hyperreactivity. Smokers have chronic bronchitis. We need to rule out bronchiectasis, any foreign body or airway neoplasm, any parenchymal lung disease, such as the previous case, which also had a dry cough, vocal cord dysfunction, cardiac disease. And if everything is excluded, there's a small percentage of patients just have idiopathic cough driven by possibly a neurogenic process. So some of the red flags, so hemoptysis, if they present with additional symptoms of dyspnea, chest pain, if they're febrile, they've got risk factors for tuberculosis. So that's a key thing in particular endemic groups. If they're immunosuppressed, they're heavy smoker or a history of malignancy, or if there's any important examination findings such as crackles, wheeze, stridor, or cardiac dysfunction. So in terms of chronic cough evaluation, this slide diagram's from up to date, but a good history and exam, if it suggests the most likely 3 causes, that being the upper airway cough syndrome, asthma, or reflux, which accounts for 90% plus of chronic cough, can treat accordingly and reassess. If it doesn't suggest that, or if the cough persists, have them do a chest X-ray, which is often done well. For those with additional symptoms of sputum purulence, smoker, they're on an ACE inhibitor, or if they're immunocompromised, assess whether they need antibiotics, look into addressing their nicotine dependence and stopping their ACE inhibitor, and trading off with AT2 blocker, which the frequency of cough is no different to placebo. And if the X-rays is normal, we go back to the 3 most common causes and sort of investigate this further with lung function tests, a trial treatment, allergy testing. So if it's upper airway cough syndrome, intranasal steroids. If there's underlying atopy or antihistamine, intranasal oral if there's no features of atopy or underlying allergic driving component. So reflux, so PPI, so usually we hit them quite hard for up to 3 months. So BD, SOMAC or Nexium, but important to look into lifestyle measures. There's a proportion of people that's not acidic driven reflux or non-acidic driven, which responds less well to PPI, in which case the lifestyle measures play a more important role. For the cough variant asthma or just asthma, or if there's eosinophilic bronchitis, inhaled corticosteroids is the treatment of choice. To discuss X-ray and lung function, so FeNO help identifying asthma or EB, and a challenge again helping identify bronchial hyperreactivity or asthma, and then decide whether they need further investigations. So a nasal endoscopy through an ENT review. And if at the end of all extensive investigation, the cough hasn't resolved or a cause hasn't been identified, consider the diagnosis of hypersensitivity. So treatment targeted at the symptom rather than the cause, so suppressing the cough, referring them to a speech path with an interest in this area. So back to our case 2, she has been diagnosed with mild asthma. As you can see, they have a pretty normal post-bronchodilator spirometry, and there's a significant post-bronchodilator response. So FEV1 improvement of 500 mils or over 12%. And this is also reflected in the flow volume loop. She has an elevated FeNO, so 133 parts per billion. Actually, it's markedly elevated. What are your treatment options? Do you go with a short-acting bronchodilator as required? A low-dose ICS formoterol is required. A regular low-dose ICS, such as Pulmicort, and a short-acting bronchodilator, such as salbutamol, is required. So in the past, we generally, in the step 1 GINA guidelines, have offer the option of SABA is required, but this recently has been changed. So the preferred option is low-dose ICS formoterol is required, such as a Symbicort. And the reason or the rationale is it reduces the risk of asthma-related exacerbation and death that we saw in patients who were just using SABA. So the key message is just because it's mild in terms of not having frequent symptoms doesn't mean they can't have a life-threatening attack. By preferring this option, there's a consistent messaging about aims of treatment, which is controlling the asthma rather than just about relieving the symptoms as needed. And it avoids the pattern of reliance on SABA, which is associated with poor control, increased exacerbations, increased risk of death, and increased airway inflammation. For those who are already on a regular ICS or prefer this option, that this is also an acceptable alternative in terms of having, starting with a controller and alternative reliever. So this is a stepwise approach with asthma. I think step 2 to 4 are quite well done in the primary care. So knowing when to escalate their ICS LABA depending on their symptom control. Again, the goals of asthma: optimize control, minimize exacerbations, avoid treatment side effects, which is particularly pertinent for those who are frequent exacerbators requiring oral corticosteroids, and managing comorbidities. So unfortunately, she did not follow up with you for several years, or 5 years or 10 years, and returns to you after returning interstate with features of uncontrolled asthma. So she now has frequent symptoms, relying frequent use of SABA that's being prescribed elsewhere. She's now had recent hospitalization and given multiple courses of oral corticosteroids several times a year. She has her own, bottles and self manages with going on her own courses of oral steroids, but not necessarily having good use of her preventer. So is this severe asthma? So differentiating difficult to treat asthma and severe asthma. So difficult to treat asthma is uncontrolled despite GINA step 4 or 5 treatment, or requiring high doses of inhaled steroids or oral corticosteroids in order to maintain control. There may be modifiable risk factors, so poor inhaler technique, suboptimal adherence for various reasons. They might be exposing themselves to other triggers such as smoking, or they have other comorbidities that's not managed, such as reflux, nasal drip, obesity, and so forth, or they have an incorrect diagnosis. So this is different from severe asthma, which is a subgroup of difficult to treat asthma. So these patients have uncontrolled, despite good adherence, with maximal optimal therapy with inhaled treatment, and also addressing the other contributory comorbidities. So this forms in the Dutch databases forms about 4% of asthmas compared to 14-12% in terms of difficult to treat asthmas. So in terms of approach to difficult to treat asthma, again, to confirm, is it actually asthma? So this is what we do in our asthma clinics. We identify contributing factors. So do they have appropriate inhaler technique? Are they using their preventers appropriately or adequately? What sort of comorbidities can we address and treat? Here are the main 5. And what triggers can we look to avoid in terms of environmental exposures? Is it a work-related asthma, occupational asthma? Smoking, allergens at home, do they have underlying medications that they're on a beta blocker or non-steroidals that's contributing? We optimize their management, so education regarding asthma, address their contributing factors, and then consider adding on non-biologics first. If it's still uncontrolled after optimizing treatment for a period of a few months, then they achieve the diagnosis of severe asthma. Next, we assess their phenotype. Do they have type 2 inflammation? So that's driven by IL-5, IL-13, so sort of eosinophilic IgE atopic asthma. This accounts for about 50% of patients with severe asthma. Some of the biomarkers include elevated serum eosinophil or sputum eosinophil, a high FeNO, and underlying atopy or positive skin prick test. In this group of patients, in addition to focusing on optimizing their basics, we can consider using biologics, and they often respond well to biologic therapy. Unfortunately, a large cluster of patients have non-type 2 inflammation. Again, the focus is on optimizing management of their basics and trigger avoidance. There are a bunch of non-biologic add-ons that can be considered, such as long-acting muscarinic, so tiotropium, consideration of low-dose macrolides, so you have to weigh up the benefit-risk with antibiotic resistance and side effects from macrolides, and consideration of thermoplasty through a registry or trial pathway. There is a new biologic, tezepelumab, that works for both type 2 and non-type 2 inflammation on a recent phase 3 trial. It's not available in Australia yet. So this is something possibly in the pipeline, so of interest. The drug does work well for, work better for type 2 inflammation, but has also shown response compared to placebo in the non-type 2 severe asthmas. In addition to phenotyping, and depending on their phenotype, to investigate for less common comorbidities, so such as heart disease, vocal cord dysfunction, any parasite or other causes of hypereosinophilia. So in terms of biologics or selecting the biologics in severe asthma, they have overlapping but also somewhat differing criteria. And then the decision of choice probably is determined by what's the main driving factor, as well as the logistics of treatment, as they have different so most are subcut, some are intravenous, some can be done at home, a different frequency of injections. There's increasing data of different predictors of good response that might help decide one biologic versus other. This is often done at a severe, with subspecialty respiratory physicians with an interest in asthma, so done in our severe asthma clinic. Again, the biologics are beneficial in terms of reducing exacerbations, reducing oral corticosteroid use, and in some studies, improve FEV1. So the key points of asthma, so important in terms of getting spirometry done and indicating there is variability, but acknowledging that there is technical performance aspects of the test. So if there's issues with getting it done at your clinic, refer to a formal lab to have it done. There has been a change in GINA step 1, so now the pushes towards sort of ICS formoterol is required. And then to step up if the symptoms are not controlled with more regular use of ICS formoterol at higher steroid doses. So only a small portion of asthmatics have severe asthma and thereby qualify for biologics. The majority of the difficult to treat asthma have other aspects that can be improved. We have a general respiratory clinic that can assess and manage chronic cough in the majority of asthmas, but there's the availability of severe asthma that you can refer directly to, again, to confirm diagnosis, review treatment, but also access biologics. It's linked in with multi-center asthma MDTs with other hospitals to discuss more difficult cases. We have sort of asthma nurses that can address asthma education and review the inhaler technique, as well as RCCP staff that can be sent to their home to assess their asthma control and inhaler technique. Let's move on to case 3. So this is a 78-year-old male, 2 weeks post-discharge from ED with non-infective exacerbation of COPD. This is their first presentation and first diagnosis. The discharge from ED with a course of prednisone, Ventolin. Advised to see GP, but recently moved here from Queensland, so showed up at your doorstep. He has a background of hypertension. He's an ex-smoker with a 40-pack year history. He's a retired factory worker, lives at home with wife, who reports he's not as fit as a couple of years ago. On examination, he's saturating 94% of room air, rest rate of 18, a regular pulse rate, unremarkable cardiac exam, including no features of pulmonary hypertension. There's expiratory wheeze on auscultation and global reduced breath sounds, and this is an X-ray that was performed recently, which showed evidence of hyperinflation with diaphragmatic flattening. So in terms of COPD evaluation, in our clinic as well as in GP clinic, so again, first to confirm the diagnosis. So do they have typical symptoms of dyspnea, cough, and sputum production? Again, this is non-specific. Often it's coupled with a history of exposure, not necessarily have to be tobacco. There's spirometry, so FEV1 to FVC ratio of 0.7, so this is a key point. Don't diagnose COPD without having them to undergo a lung function test. And then imaging to exclude other mimickers or differential diagnosis, or to detect if they've got comorbid disease such as heart disease or bronchiectasis or fibrosis. Identify causal contributing factors that can be addressed and alleviated, so often tobacco smoking, but globally it's increasingly there's environmental pollutants, so there's pollution, biofumes, anything occupational that they're exposed to, any other recreational drugs. Assess their grade of severity, so this is based on their spirometry. Again, it's important that they undergo a pre and post bronchodilator spirometry. So the severity based on their post-bronchodilator spirometry divided into gold stage 1, 2, 3, and 4, depending on their percentage predicted FEV1. However, it has a weak correlation with symptoms or exercise capacity, as well as health status and impairment. Some prognostic use, but again, not very strong. The focus is more addressing their symptom burden, so MMRC, so the breathlessness scale, as well as their COPD assessment. So symptom burden in terms of cough, tightness, exercise symptoms, sleep and energy levels, as well as their exacerbation risk. The best predictor of exacerbation risk is a history of exacerbation, as well as their exertional symptoms. The risk change with time, so they often have the clusters of exacerbation and they are symptom-free for a period of time. This is a target for treatment in terms of introduction of inhaled corticosteroids. So if they're not a frequent exacerbated or have severe obstruction, often we avoid inhaled corticosteroids, as it is associated with increased risk for pneumonia, as well as other side effects. Then we identify any phenotypes and any comorbidities to assist with personalizing treatment. So lung function tests in terms of the lung volumes to indicate degree of hyperinflation, whether they suggest a degree of emphysema based on the reduced diffusion capacity, or possibly indicating presence of coexistent fibrosis or pulmonary hypertension. The distribution of emphysema on CT, any airway wall thickening, which predicts chronic bronchitis and frequent exacerbation. Again, coexistent comorbidities. Serum eosinophil is a marker that might indicate benefit from inhaled corticosteroids, or alpha-1 antitrypsin deficiency, which is actually one of the few treatment targets. In terms of prognosis, so the long-term prognosis is determined by their symptoms, history of exacerbation, and severity of airflow limitation, as well as the presence of comorbid conditions such as cardiac disease. Chronic hypercapnia is a poor prognostic marker. There are sort of scores that can be used that incorporates different markers in terms of overall prognosis. We go back to case 3. He assumed he had asthma, but long-standing history of chronic cough and exertional dyspnea. He has quit smoking since his original ED presentation. There's no other environmental or home exposure to noxious inhaled particles. He does have severe obstruction, as indicated by his formal lung function test, and sort of quite severely reduced DLCO. He reports an MMRC of 2, currently have overall low burden of symptoms, reports yearly exacerbation, and has a raised eosinophil level. This is a CT, which has a central lobular paraseptal emphysema. So in terms of long-term management, they can be divided into symptom directors, so relieving symptoms, improving their quality of life and exercise tolerance, or outcome directors, so preventing progression, preventing exacerbations, and reducing their mortality. So treatments that avoid, more outcome-related directives, so exposure avoidance, so stopping the, further deterioration of lung function in terms of smoking cessation, changing their cooking methods, probably more relevant in overseas. Appropriate ventilation and PPE for occupational relevant ones. So infection prevention, so immunization, education on respiratory hygiene, which is important in current circumstances that we're faced with. And in terms of more symptom-directed ones, so pulmonary rehabilitation, teaching and breathing techniques. Primary physicians are welcome to refer directly to our pulmonary rehabilitation. Currently, there is a waiting time due to the impact of COVID. We are doing a lot of telehealth and visits, even with our pulmonary rehabilitation. So those inhalers address both symptom and outcome directed. So LAMA improve lung function, symptoms, quality of life, as well as reduce exacerbations. Inhaled corticosteroids more addressing exacerbations, but can also improve quality of life. Has little impact on lung function. The choice of inhalers, depends on the patient choice. So whether they have sort of more slow, steady inhalation versus sort of a large inspiratory flow determines whether MDI or DPI is the most preferred choice, as well as their coordination and technique. Again, back to asthma or any chronic lung conditions, addressing and treating the comorbidities, and there's quite a few associated with COPD. In the past, we saw COPD as a lung condition, but now it's part of accelerated aging often coexistent with multiple other comorbidities such as cardiac disease, cognitive decline. So in terms of acute exacerbation, the general principle, it's done well in the GP clinic. So early treatment, short-acting bronchodilators, a short-term course of moderate dose steroids, and assess whether they need antibiotics. So our patient has a respirator of 28 and SATs of 90%, appearing fatigued despite treatment with above over the course of 24 hours, and appropriately is referred to ED. So sudden worsening of dyspnea, tachypnea, reduced resting oxygen saturations, altered mental status, and insufficient response to short-acting bronchodilators. So he returns to you after being discharged with hypercapnic respiratory failure and come to you with issues with his now BiPAP mask and complaints of persistent dyspnea. So what can we do for you? So there are additional COPD interventions. So we review their triple inhaler therapy, assess whether they need home oxygen therapy. This patient is already on a nocturnal bilevel, and any PAP, positive airway pressure issues, we can refer back to the respiratory failure clinic if they're on bilevel treatment, or CPAP if they have coexistent OSA. So this is a time just to opportunity to discuss. So we divide our sleep or respiratory failure clinics into three. So sleep for any new referrals. So most of it is query OSA or insomnia, so the pre-diagnosis. CPAP for patients who are established on CPAP, patients who are on CPAP, often newly established, or they need licensing clearance or issues with compliance. Otherwise, we often refer back to you. And then for the more complex disorders, so mixed, obstructive central, if they got hypercapnic COPD overlap, obesity, hyperventilation, or neuromuscular disorders, or any trachea patients, they're seen regularly at the respiratory failure clinic. In terms of other COPD interventions that we can link them up to, so lung volume reduction, if appropriate, so heterogeneous emphysema, whether appropriate for transplant, and then linking them with palliative care and advanced care discussions. So to summarize, refer to us if you wish for more comprehensive diagnosis and phenotyping, for us to review their inhaler technique or personalized treatment, and investigate and treat their comorbidities, or if they have frequent exacerbations or refractory symptoms. So services offered, so lung function lab, radiology meeting to discuss their scans, or incidental nodules, sleep laboratory to investigate for comorbid sleep disorders, which are quite frequent in the chronic respiratory population. We have RCCP, which is outreach respiratory nurse and physiotherapy service that can educate them on inhaler use, breathing techniques, breathlessness management, teaching them home exercises, as well as surveillance and early treatment for our frequent exacerbators. Possibility of having a future breathlessness clinic that COPD would be the ideal population to be linked in with, and then again linking with palliative care services or any interventional services or transplant referral. Next case, case 4. So 62-year-old female, incidental right upper zone, rounded opacity on chest X-ray, on a background of osteoarthritis. So this X-ray was done as pre-OT for a total replacement. That's elective, obviously. They've got a background of atrial fibrillation on warfarin. Pathetic smoker, 20-pack year history, no weight loss, hemoptysis, or chest pain. So you've gone ahead based on X-ray to organize a CT chest. There's an upper zone nodule, but also subcarinal lymph nodes enlargement. So this patient is appropriately referred to the respiratory clinic with suspected primary lung cancer with possible mediastinal involvement. Patient was organized to have a PET CT urgent lung function test given the smoking history. We chased their cardiac correspondence and transthoracic echocardiogram The warfarin withheld. Outpatients' bloods was organised through our RCCP and was booked for a EBUS-TBNA. So that's endobronchial ultrasound with transbronchial needle aspirate. This allows mediastinal and hilar lymph node sampling as well as any central airway lesions. The bleeding risk is equivalent or even less than bronchoscopic forceps biopsies. So allow access to for diagnostic and staging purposes. And in this case, given the central nature of the upper lobe lesion, it was felt that the EBUS was the safest, which also achieves both diagnosis and staging. Often, a rapid on-site cytologist is available to review the specimen samples to give us on-site feedback about whether additional sampling is required. In systematic review and pooled results, which has obviously very good specificity of 100% and a sensitivity of over 90%. So this is a picture of the EBUS probe down bottom left, which shows it allows bronchoscopic, so normal bright light visual of the airways, and then ultrasound to visualize more deeply for any lymph nodes, but to differentiate from blood vessels or other structures that you would want to avoid. The bottom right picture shows a needle entering a lymph node, and this is what we see on the ultrasound on the EBUS probe. So back to case 4, we achieved the diagnosis and staging. So on-site cytology indicated adenocarcinoma with suggestive lung primary after formal staining. This was found in station 2, but not station 3. So there was sequential nodal sampling, depending on their size on ultrasound during the EBUS procedure. And additional samples were sent for cell block for additional receptor testing. So it was referred to a lung cancer MDT, discussion whether the patient would be for surgery, and the treatment consensus was a concurrent platinum-based chemotherapy plus full dose radiation treatment. They're linked in with cancer services, as well as dietitians and social work. So the key points from a lung nodule or cancer perspective, so valuable information for triaging, is it just an incidental sub-centimeter nodule? Whether there's sort of new and old, has it changed in size? Or is it sort of a mass lesion, plus or minus, do they have lymph node enlargement on their CT? Are there features of METs? And what symptoms they have? So consider direct ED referral if there's significant hemoptysis, uncontrolled pain, concern regarding brain METs or spinal METs, if they present with upper airway compression symptoms, so stridor or significant breathlessness, suggesting effusion. It's often helpful to have the patient bring their films or any old ones. Often we find that the nodule was present several years ago, so it potentially doesn't require any further investigation. If not, the CT report and the location of the CT is useful in the referral letter. Any additional information regarding the fitness for diagnosis or treatment? So other comorbidities, any presence of cardiovascular disease, whether they're on antiplatelet or anticoagulation, which might need to be withheld for any procedural purposes, whether it's a CT-guided biopsy or bronchoscopic procedure. And again, the emphasis is referring to a respiratory physician for diagnosis. The medical oncologist generally, their role is once diagnosis and staging is completed. And we can help link them up with the medical radiation oncologist through MDT service. So case 5, go with the time. So 73-year-old female, difficulty falling asleep, multiple awakenings at night, difficulty reinitiating sleep. Husband reports some snoring, but she denies. There's background of anxiety, depression, hypertension, CKD. She's a retired nurse, non-smoker, but social alcohol. She's saturating well on room air, blood pressure is 160 on 90 millimeters of mercury. There's mild low in edema. Her chest is otherwise clear and cardiac exam unremarkable. She has a BMI of 34, so a crowded oral airway with an overbite, and so modified Mallampati score of 3. So she fits the definition of insomnia. So subjective complaint of poor sleep quality, so either difficulty initiating sleep, difficulty maintaining sleep, or waking up earlier than desired. And this is despite adequate sleep opportunity, and it is impairing their daytime function. Has to be 3 nights per week, and to satisfy the chronic insomnia definition had to be at least over a 3-month period. There are assessment tools in terms of insomnia severity index to assess the impact on the patient. In terms of insomnia evaluation, we identify any predisposing factors, any precipitating factors, and perpetuating factors. So oftentimes there's probably not much can be done regarding predisposing factors. By the time they see us, often the acute insomnia has transitioned to chronic insomnia. So the precipitating events are often have often resolved or improving. So it's mainly the perpetuating, so more behavioral cognitive factors that is driving the insomnia symptoms. So this is reflected in this graph of time versus insomnia severity. Different patients have different levels of predisposing factors. Often there's a precipitating event that drives them past the insomnia threshold and the development of insomnia, which improves with time and gets replaced with perpetuating factors. And this is the main thing that we're left dealing with. Some of the predisposing factors, so genetic family history, their previous developmental history, any childhood experiences in trauma, PTSD. There are sort of age, so female, more common, gender, so elderly, and ethnic background. People with shift workers, such as nursing, are more predisposed. Type A personality, the degree of stress tolerance, their history of anxiety, depression, and whether they've got chronic medical conditions such as chronic pain. Precipitating event could be sort of a severe accident. So often we find people post motor vehicle accident or another medical illness that lands them in ICU or prolonged ICU stay or prolonged rehabilitation that really disturbs their sleep-wake cycle, or after major surgery. If they have an occupation change or a significant educational barrier such as exams, HSC, physician's exams, or recent social stress such as bereavement, divorce, or conflict, often post-pregnancy or during pregnancy, so lots of change then both physiological, social, as well as dealing with the postpartum baby crying factor. Even in men, there's sort of postpartum issues that can lead to insomnia. And whether they have negative thoughts or poor coping mechanism associated with the precipitating event. So some of the perpetuating factors, so sleep hygiene, or they have negative or poor compensatory behavior, so spending excessive time in bed in an effort to give themselves enough sleep opportunity, which in turn leads to more fragmented sleep and sleep maintenance insomnia. So in some cases, excessive caffeine use to address their daytime symptoms, or excessive alcohol or medication use to address their fragmented sleep, which in turn leads to more daytime symptoms. Both of these sort of fracture the day-night, sleep-wake differentiation in patients. Some patients respond by napping, which is horrible for them, for nighttime consolidated sleep. Some people develop maladaptive thoughts and anxiety around sleep or lack of sleep. So in our case, additional history, she has always been a poor sleeper, again, shift work as a nurse, a long-standing history of delayed sleep phase, which is maintained post-retirement. She has poor sleep hygiene, so leaves the TV on at night, checks Facebook or her phone in the middle of the night when she can't sleep. She has been drinking more recently to assist with sleep onset, which in turn probably affecting her sleep quality and sleep maintenance. She replies that melatonin doesn't work. She has symptoms of nocturia, whether it's linked to alcohol or underlying kidney disease or antihypertensive drugs. She has mild restless leg symptoms. Her husband has reported snoring, but which probably is long-standing, but recently more gasping arousals. So suggests maybe she's developing or worsening obstructive sleep apnea. The patient denies being asleep at some times when the husband denies snoring or arousal, so there's a perception factor. There's frequent leg movements at night, and recently there has been conflict with her daughter. So she undergoes a diagnostic sleep study. We don't always do one for insomnia patients. So if there is underlying suspected other primary sleep disorders, such as sleep-related movement disorder or sleep-related breathing disorder, such as obstructive sleep apnea, it is performed. In her case, she has a mix of central and obstructive episodes, but mostly obstructive sleep apnea. Her sleep diary confirms that she has a delayed sleep-wake phase. Her average estimated time spent asleep is 6 hours, and average time in bed is around 9 hours. So there's a mismatch in there, which sets her up for failure. So she's given education on sleep hygiene. So we divide it into day, evening, and bedtime. So look to address in terms of getting the patient to have a regular routine, avoid daytime naps, spend more time outdoors, so increase sunlight exposure or bright light exposure during daytime, and exercise. Physical exertion leads to better quality of sleep at night. In the evening, or late afternoon, avoid caffeine intake, using relaxation tasks. Again, minimizing light exposure, so that's TV, laptop, and phone, and avoiding any alcohol. So bedtime, so have a pre-bedtime routine. So sleep restriction is so limiting her time in bed, so to be in line with the estimated sleep, so anchoring a wake-up time. And stimulation control therapy, so bed equals sleep and nothing else. So no smartphone, no TV, no staying in bed thinking or planning the day ahead. If after what the patient perceives of 5 to 15 minutes of not being able to sleep, to leave the bedroom, and if they can't do that, sit out of bed, just to create that barrier where lying in bed is not associated with the stress of not falling asleep. Often we refer them to see a sleep psychologist, so that's more advanced treatment, so multi-component therapy, so addressing multiple, so stimulus control, sleep restriction, and optimizing their sleep hygiene at the same time, and that's often coupled with cognitive behavioral therapy, paradoxical intention, so instead of getting the patient trying to think about sleep, it's actually using the opposite strategy to try to avoid sleep or try to stay awake. Often have a contradictory or paradoxical effect, which is good. Biofeedback CBT, relaxation therapy, and also in this case addressing the underlying anxiety and social stresses or conflict resolution. In her case, so we need to address other sleep pathologies. So her sleep apnea is contributing to potentially sleep maintenance as well as sleep onset insomnia. Often it's a bit harder to get patients with a comorbid OSA and insomnia to be established on CPAP therapy. So often, we start with insomnia management and introduce CPAP more generally later or at the same time. She has mild restless legs as well as frequent periodic limb movements. So investigating that, does she have iron deficiency, and managing that with behavioral management. She has nocturia, so looking at her fluid intake and medications to see if that can be addressed. So that's not driving her nocturnal arousals. Okay, so how are we doing for time? We're just a little bit over. So last case, a couple coming to your clinic, contracted COVID 6 weeks ago, well, first 2 weeks with just upper respiratory tract symptoms, that's mostly resolved, and then gets hospitalized after breathlessness in week 3 and 4 was increasing breathlessness. In the ED, they have evidence of hypoxic respiratory failure due to COVID pneumonitis, as you can see on the CT. They also have a presence of pulmonary embolus. And as a result, they had a prolonged stay in hospital, weaning off high flow steroid treatment and anticoagulation for this pulmonary embolus. Now they present to your clinic concerned about long COVID. They have symptoms of fatigue, dyspnea, and cough. So what now? So it's any symptom beyond 4 weeks is termed long COVID. Can be physical or psychological or neurocognitive. The most common symptoms of fatigue can be up to 87% and dyspnea up to 71%. They can also present with less common physical symptoms, some neurological such as vertigo, myalgia, insomnia, sweating, GI symptoms. And often they have psychological and neurocognitive, so PTSD, in particular those who had severe disease or were admitted to ICU. In the UK multi-centre observational cohort, only 29% were fully recovered by 5 to 6 months. 20% had a new disability or new symptom by 5 to 6 months. 20% had to change their occupation due to health-related reasons. Risk factors for long COVID include being female, middle age, having comorbidities, and more severe acute illness. The comorbidities such as stroke, cardiac disease, COPD, diabetes. So assessment. So we look at their persistent symptoms from their acute illness and try to differentiate sort of a post-ICU syndrome. Any late screen and investigate for any late complications such as bacterial pneumonia, pulmonary embolus, myocardial injury, and inflammation, and assess the neurocognitive and mental health aspects. So often there's overlapping features between long COVID, prolonged hospitalization, and post-ICU syndrome, and other hospitalization complications. For most of the patients, they can come and see you in the clinic as they are often de-isolated. The majority of them get a de-isolation letter from the community team, and that's sent to their corresponding GPs. However, many patients don't have a regular GP or have a stigma associated with COVID. So it can be difficult for primary physicians trying to clarify whether they are safe to come to your clinic. Obviously, there's a wide variety of symptoms that may be difficult for GPs with limited resources to sort of expect you guys to sort them out or monitor them. So we are in the process of developing a local post-COVID follow-up clinic, probably telehealth initial, organised for them to have an X-ray if required, if they had features of pneumonitis, if they've got symptoms, and then consider whether they need a lung function, further imaging based on their symptoms and initial X-ray. Likely will be multidisciplinary, and we'll link them up with pulmonary rehab if required, rehabilitation medicine and neurology, as well as respiratory subspecialty clinics if there were features of fibrosis or pulmonary hypertension. We might model on something similar to what the UK has done. They divided their patients into their severity. So if they required HDU, ICU admission for very severe pneumonia versus mild to moderate pneumonia, mostly cared for on the ward or in the community. In terms of general feedback from respiratory and sleep departments, so if the primary question or suspected problem can be clearly identified on the referring letter, so we can triage into the correct clinic, so respiratory or sleep. And if it's sleep, whether it's a new OSA versus a CPAP checkup versus insomnia versus possibility of more complex ventilation disorder. So their weight and BMI is often helpful. And respiratory, is it a difficult asthma? Is it an interstitial lung disease? Is it a cough, nodule, or COPD, or undifferentiated breathlessness? An idea of acuity for triaging. So patients with suspected lung cancer, hemoptysis, any lung presentations with functional limitation, or sleepy drivers get triaged priority, obviously. And then any supplemental information, again, to emphasize if the patients have films, old or new, if they can bring it in, it's even better. Any questions? This is my contact details, so feel free to email me. Any questions? Happy to address anything that's not covered in the talk.
There you go.
Or any questions arising from the talk. Okay, all right. So is there a specific ILD clinic? Yes, so we do accept referrals directly. So this is a question from Dr. Gleason. Is there a specific ILD clinic? Do you accept referrals directly from GPs, or do we need to refer to a respiratory physician who will refer to the clinic? So there's a specific ILD clinic, and they do accept referrals directly from the GPs. They can go through, the occupational history, exposure history, organize the CT scan and blood panel themselves. Obviously, any local respiratory physician are more than happy to see any interstitial lung disease referrals and coordinate care. And oftentimes, they can bring the case to the MDT give an opinion, and then the case is re-referred, connected with their referring respiratory physician and can manage from there on. But by all means, GPs are welcome to refer directly. And that's it.
I think that was the only question. So thank